Hi everyone, my name is Arran Seiler. I'm the Obstetric Anesthesia Fellow over at the University of Chicago, and I'm here to talk to you about postpartum hemorrhage. So just a little background information on postpartum hemorrhage. There can be varying definitions. However, for the purpose of this talk, we will use 1,000 milliliters of blood. Previously, there have been discrepancies between whether it's a vaginal delivery versus a cesarean delivery. However, from a physiologic standpoint, the body doesn't know how it loses blood, and so for simplification, we will go with 1 liter. It is the leading cause of maternal death worldwide. Thankfully, that is not the case here in the US. However, it is still one of the top causes of severe maternal morbidity. It is increasing in frequency. As of 2014, about 3.2% of all deliveries are complicated by postpartum hemorrhage. And then severe postpartum hemorrhage, which is defined as anything greater than 1.5 liters, happens in about 15 to 20% of all postpartum hemorrhage cases. So what are the causes of postpartum hemorrhage? So the number one by far is uterine atony. This is about 80% of all cases of postpartum hemorrhage are due to poor uterine tone. And so we will talk more about this. Genital trauma can be another significant cause of postpartum hemorrhage, whether that's a tear during delivery or use of forceps or anything else that's going on. Any injuries to blood vessels can lead to significant hemorrhage, especially if it is retroperitoneal, because that is not readily apparent to the providers. Retained placenta, which occurs in about 3% of all deliveries, that can also be a significant cause of postpartum hemorrhage, and part of that circles back to poor uterine tone. And then anything along the placenta accreta spectrum, this can be a source of significant hemorrhage, and this is also increasing in frequency within the US. And then coagulopathy. Patients can be taking anticoagulant medications such as heparin or Lovenox for any number of reasons. Usually low-dose aspirin, which we use for preeclampsia prevention, is not a significant cause, but patients can be given new medications during the course of their hospitalization for other problems, or patients could develop disseminated intravascular coagulation due to part of their pathology. These things sometimes will also be referred to as the 4 T's, first one being tone, second is trauma, and then tissue, that would be retained products of conception, and then thrombin is the 4th T, and that circles back to coagulation. So now that we've gone over some of the main causes, let's talk about some of the significant risk factors. So a history of postpartum hemorrhage will certainly increase your risk of having postpartum hemorrhage again in the future. Uterine atony, which I had mentioned on the last slide, is by far the most common cause of postpartum hemorrhage, and so there are lots of risk factors that go into this, and these can be broken down into several different categories. The obstetric management of a patient can play a role, so cesarean deliveries are at higher risk. People who need their labor to be induced and or augmented, and this is due to prolonged and high doses of oxytocin, those will increase uterine atony risks. There are obstetric issues, so multiple gestations can do it. When the uterus is large, it can be the case for macrosomia or polyhydramnios, then that can increase your risk. Prolonged labor certainly does, and then chorioamnionitis will also increase your atony risk. There are maternal issues to consider, such as advanced maternal age, diabetes, and hypertensive disorders. And then there are medications that we give that will increase your risk of uterine atony. These can be tocolytic drugs, magnesium, which we frequently use for preeclampsia with severe features or for severe prematurity. And then anyone who's getting volatile anesthetics because they are having a cesarean delivery under general anesthesia, those medications will also decrease uterine tone. There's a study that I'll mention on the next slide. They looked at risk factors for postpartum hemorrhage, and one of the things that they found was that low birthing centers or low volume birthing centers, so anywhere that does less than 500 deliveries a year. And part of this is just because these centers, due to their lower volume, when they have postpartum hemorrhage, they may not be as quick to recognize it and as well adept at managing it. And retained placenta, as I had mentioned before, and anyone taking anticoagulant medications is going to be at higher risk. So now I'll go over a brief history of how we got to where we are today in our management of postpartum hemorrhage. So in 2001, there was a study out of France that was looking at risk factors for postpartum hemorrhage, and the two biggest things that they found were one, small facilities, which they defined as anywhere that performed less than 500 deliveries a year, or anywhere that did not have on-site 24/7 anesthesia providers. Both of those increased risks of postpartum hemorrhage. 10 years later, another study in France, they were looking at people who had postpartum hemorrhage and try to figure out what factors are related to the severity. And the biggest thing that they found was delay in oxytocin administration. Patients whose administration of oxytocin was 10 minutes or longer were at elevated risk of postpartum hemorrhage, and anyone who had a delay of 20 minutes or greater was at significantly higher risks of postpartum hemorrhage. There were two studies out of California by Shields in 2011 and 15. I'm going to talk about these studies more later because these are very, very important ones. But the main thing is that they implemented a protocol for their hospital and saw the effect that it had, and it improved the staff's comfort level and their awareness of what to do. It resulted in patients being treated much earlier and promoted an environment of safety. 2015, there was another article by Maine, and whenever you hear about the 4 R's of maternal safety, such as readiness, recognition, response, and reporting, that is related to this article. And the other thing that this article did was it just re-emphasize the importance of active management of the third stage of labor and giving oxytocin as soon as possible. In 2017, there was a study out of Norway. This study was looking specifically at severe postpartum hemorrhage and looking at the risk factors for that. Uterine atony was still the number one cause of severe postpartum hemorrhage. However, it went from 80% to 60%, which means that of cases of severe postpartum hemorrhage, some of the other causes of bleeding take a more important role, particularly anticoagulant medication and retained products. Those are more frequently associated with severe bleeding. Then earlier this year, there was a study that showed, despite the fact that postpartum hemorrhage is increasing in frequency in the U.S., maternal death is decreasing because we are better at recognizing it, we are better at managing it, and this is proof that the things that we are doing to intervene on postpartum hemorrhage are having a significant difference. And then also earlier this year, there was a study out of New York looking at objectively measuring blood loss in the form of a QBL, a quantitative blood loss, versus an estimated blood loss, which is what we traditionally use. And for vaginal deliveries, they showed that objectively measuring the blood loss resulted in a much wider range of blood loss values, and also it improved early administration of secondary uterotonics such as methergin and hemabate in vaginal deliveries because providers were able to see earlier when a hemorrhage was actually happening. So here is the Shields protocol that I was talking about in the last slide. Now, what's important is not necessarily the specifics of this protocol. I'm just using this protocol to show you what they did. What is important is that your facility has a protocol in place and that people there rehearse it, they understand it, they know what's happening. That is the real takeaway value, is to have a protocol, not necessarily to emulate this one. But, so that being said, stage 0 of the protocol was just any normal delivery. So blood loss less than 500 for a vaginal delivery or less than 1,000 for a cesarean delivery. That was normal, so nothing to do other than routine management. And this is what I was talking about before, how in some sources there will be differences in the definition of postpartum hemorrhage depending upon the route of delivery. But if the blood loss exceeded either 500 or 1,000, depending on the route of delivery, they would advance the patient to stage 1. So here on this slide, you see how stage 1 management goes through their study, and they have different values, as I mentioned, for vaginal or cesarean delivery. Vaginal is on the left, and cesarean is on the right. But the main things that are important here is when you recognize that your blood loss is higher than what they defined as normal, that you call for help and then you start administering your secondary uterotonics. And then if needed, try uterine massage, empty the bladder, etc. In stage 2, so this is just vaginal. This is anyone that does not respond to the secondary uterotonics. And what they do is they notify their shift leader, they notify the house supervisor. Really, what is important here is that once they have recognized that their secondary uterotonics are not working, they're calling for more help, they're starting IVs, they're drawing labs. Basically, they're just getting more people on board and doing more things to prepare the patient. They would also have a drug cart, and that drug cart can be whatever your facility decides is important. But basically, it is equipment for managing hemorrhage, such as perhaps a Bakri balloon, it's IV supplies, it's blood draw tubes to send to the lab to evaluate for things like DIC and CBCs. The specifics of it, as I mentioned, are not very important, but what is important is that you have a protocol. This is stage 2 for cesarean deliveries. So some of the things are a little bit different because in this scenario you are already in the operating room, you have a surgeon there, and you have an anesthesiologist present. But really it is ultimately coming down to recognizing that your initial managements of hemorrhage aren't working, letting everyone know, calling more help as needed, and doing the things that need to be done to help the patient. And then stage 3 is when all of that is not working effectively and your EBL is over 1.5 liters, and now you're in the severe postpartum hemorrhage world. So if you're not in the operating room, you should get to an operating room. You may already be there if this is a cesarean delivery. But ultimately, in a very simplistic sense, all it is recognizing, communicating to everyone, getting more people involved, and then getting IV access, drawing labs, talking to the blood bank, calling interventional radiology if that's an option at your facility, and then considering doing a hysterectomy. So why are the SHIELD studies so important? First, by having this protocol in place that people rehearsed and that they understood, it resulted in more patients being successfully treated at earlier stages of hemorrhage. That earlier treatment meant that people bled less, which meant that there was a reduced amount of blood products that needed to be transfused. Because of that reduction in blood loss, there was a reduced rate of disseminated intravascular coagulation. And this part, I think, is immeasurably important. They did a survey of the nurses and the physicians after implementing this protocol, and people felt like having this protocol in place improved team communication. They felt more comfortable and more confident in knowing what's going on and how to manage the hemorrhage, how to treat it, how to call other people, who to call. And it also developed this culture of safety within the labor and delivery units, which I think is incredibly important. And then in the 2015 study, there was a slight reduction in the number of hysterectomies. Thankfully, peripartum hysterectomies are very rare, so this was just not a statistically significant change. However, it did decline. So oftentimes people will hear about maternal safety bundles, and this can be for hemorrhage, it could be for hypertension. There are all sorts of bundles out there. The website that you can go to is safehealthcareforeverywoman.org. I'm going to leave that there for everyone to see and copy because this website is full of information and I can't get into all of it. But the 4 R's that I had alluded to earlier: readiness, so that's having everything in place, the equipment that you need; recognition and prevention, so knowing what the risk factors for postpartum hemorrhage are and acknowledging when postpartum hemorrhage is occurring; a response, so starting oxytocin earlier, calling for help, and then reporting as the final R. And this is establishing good communication between team members, having a huddle afterwards to review everything, and passing this information on. So in summary, postpartum hemorrhage is increasing in the United States up to about 3.2% as of 2014. Recognize the risk factors and have a plan in place for when patients come in. Know if they're on anticoagulant medication or if they've had postpartum hemorrhage in the past or if there's anything else such as a bleeding disorder that they have, so that everyone can be on the same page about those patient's risk factors and have a plan in place for the management of that patient should something occur. Timely management of the third stage of labor is crucial. Delays in oxytocin increase postpartum hemorrhage severity. Have a protocol in place on your unit. The protocol does not need to be the same as the protocol from the SHIELD studies. Every L&D unit is different. Know what works well for you. What is important is not the specifics of the protocol, but that you have a protocol, that it is rehearsed, that everyone on the floor understands it, they run through it, and that whenever there is an incident, that there is a debrief and you can work through the problems, tweak things, adjust things as needed. But what is important is that there is a protocol in place. And then QBL leads to earlier intervention. And the main reason for this is that when you have an objective measure of blood loss, and this is particularly for vaginal deliveries, it is easier to recognize when postpartum hemorrhage is occurring because you objectively have a volume of blood that everyone can see. And then the earlier you recognize it, the earlier you intervene on it, and that is what saves lives. Thank you. Here are my references in case anyone wants to do some research of their own. Thank you.